Pleasure to have Dr. Ashita Tolwani visiting us from University of Alabama. There she's a professor of medicine in the Division of Nephrology. She's also the Associate Director of ICU Nephrology. Originally, or at least spent a good number of formative years in the Pacific Northwest, but has since been out in Alabama for her MD training, residency, nephrology fellowship, add-on ICU fellowship that she cobbled together at the time. It was uncommon. She did a master's in epidemiology at Harvard, and I mean, clearly a trailblazer in ICU nephrology. Suspect it will be self-evident from her talk, but she's also a clinician educator. She leads the fellowship. She's led the fellowship program in multiple roles, currently the associate director. She leads the medical school course, which I think got top marks last year. Yes, which she attributes to treats for those who are curious. She's had lots of institutional awards from University of Alabama for her teaching, and not insignificantly the ASN Robert Narins Award for Lifetime Achievement in Teaching in 2020. Not sort of notably missing from her CV is what I assume is most top 5% of most interesting nephrologists in the room, or something along those lines, for her for her being a Halloween enthusiast, Zumba instructor, beekeeper, among other things. Hopefully those will come up in her presentation, if not afterwards, right? Truly a pleasure to have Dr. Ashita Tolwani. Thank you for coming.
So, thank you for that wonderful introduction. And I am so honored to be here and humbled to be here with you today. And just to correct something, my husband's a beekeeper. I just keep getting stung by them. So let's just get that straight. So thank you. So today I would like to present a talk basically on the current evidence in acute renal replacement therapy in the ICU, and specifically focus on what we know and what we don't know. These are my disclosures, which are not related to this talk. So what I'd like to do today is really analyze the available evidence regarding the ideal timing of initiating renal replacement therapy in critically ill patients with acute kidney injury, evaluate the current dosing recommendations for renal replacement therapy, and if we have some time, discuss the best anticoagulation approach for renal replacement therapy as to what the evidence is today. So when you think about prescribing renal replacement therapy in acute critically ill patients, these are the questions that we come across. When should therapy be initiated? What is the best renal replacement therapy modality? What is the optimal dose? And what is the optimal anticoagulant? So let's see if we can go through what we know today about these questions, and we'll start with the first one. So if you look at the KDIGO guidelines, which are now over 10 years old, this is what they state. Yes, initiate renal replacement therapy for those life-threatening indications we all know, but they also say consider the broader clinical context, the presence of conditions that can be modified with renal replacement therapy, look at trends rather than a single test. So this is back in 2012. Where are we now in terms of this recommendation? Well, first of all, we have to discuss what do we mean by timing? We talk about earlier versus late. Well, what does that mean? So conventional or late is what you all are aware of, is starting renal replacement therapy when patients develop those life-threatening indications as listed here. Early means, of course, starting it earlier to the onset of those life-threatening indications and more preemptive. And if you look at the studies that have been done recently, which we will go over, most of them report earlier by a stage of AKI, either starting at KDIGO stage 2 or 3 prior to one of those indications. And the hope, of course, is that we will prevent life-threatening complications of acute kidney injury. So what are the benefits and disadvantages of early initiation? As I mentioned, potentially we could reverse the complications or prevent the complications of uremia, control volume, which is a big issue in ICU patients, prevent electrolyte derangements and acid-base derangements, possibly help with immunomodulation, And really, what I think is important is to mitigate distant organ effects, such as congestion of the lungs, congestion of the heart, congestion of the liver. But we all know the risks of initiating renal replacement therapy as listed on this slide. There are risks of vascular access, risks of anticoagulation. There is iatrogenic hemodynamic instability. We know that hypotensive events can cause worsening ischemia in the kidney. We also know, depending on what modality you use, you can have extensive loss of micronutrients and antibiotics, which are vital to these patients. And there's this unnecessary exposure to dialysis, which is an inflammatory procedure to begin with. And of course, we have to think about the increased workload, the costs and resource use. So what I'm going to go through is some landmark trials that have been published since 2016, the randomized controlled trials, and talk about what we know now. So what I'm going to focus on are these 5 trials listed here from 2016, the Elaine trial, the Acute trial, the Ideal ICU trial, the START AKI trials, and finally the Acute 2 trial. I don't have time to go through each trial in detail, so I've really kind of made a summary in the slide of the first 4 trials I mentioned. So these were all trials done in critically ill patients that acute kidney injury, adults. They either required mechanical ventilation or depended or had vasopressor dependency. Essentially, out of these 4 trials, I've highlighted one in yellow. This was the Elaine trial, which was done in Germany. It was a single center trial. And the reason I highlighted this in yellow, because it was the only positive study in terms of indicating that earlier may be better. So let's look at these trials. So Elaine trial was a single center study, a smaller population than the other trials. The Ideal ICU, which is a 3rd trial listed in this slide, were patients who had also septic shock. So differences between the Elaine study and these earlier studies, or these other studies, was some of the things I've highlighted here. First of all, the study population in the Elaine trial was mostly surgical, while for the other trials, we had a mixture of medical and surgical patients. In the Elaine trial, the early arm was KDIGO stage 2, an earlier staging of AKI compared to some of the other trials listed in this slide. Interestingly, the patients in these trials who are randomized delayed arm, in the Elaine trial, 91% received renal replacement therapy. But in the other trials, anywhere from 50 to 60% received renal replacement therapy. And the reason for that is they either died before initiation of the therapy or recovered kidney function. There's also differences in timing and modalities. In the Elaine trial, the only modality used initially for these patients was purely CRRT, while in the other trials, there was a mixture of intermittent hemodialysis, CRT, or even prolonged intermittent renal replacement therapy. So some may argue perhaps the signal we see in the Elaine trial is because of the different patient population, or maybe the modality used. But you have to keep in mind that it is a small single center trial. So if you look at the fragility index, it was 3, meaning if 3 patients were by randomized to the other arm, it would have made the trial negative. So you have to keep that in mind of how realistic are these results, especially when you're looking at other studies such as a START AKI, which is the last trial listed here, of over 3,000 patients. And in that trial, when they looked at different subgroups, such as surgical patients, they didn't have the same finding. So just keep that in mind. So, okay, what we know from these trials, or most of these trials, is there doesn't seem to be a benefit for starting earlier by a staging criteria of AKI. So perhaps waiting and watching is okay. But if we can wait and watch to some of those other indications, some of the conventional indications, which were the indications in the late arms, then maybe there's a benefit in delaying it even further. So this was the Acute 2 trial, and they asked, can we delay it even further, and do we have bad outcomes? So again, the same people that did the Acute first trial, which was different groups in France, they randomized adult ICU patients, either who had mechanical ventilation or pressors, who had stage 3 KDIGO. And when they achieved oliguria, more than 72 hours, or a BUN of greater than 112 milligrams per deciliter, and did not have an emergent indication for dialysis, they were either randomized to the delayed strategy when they met that criteria, or a more delayed strategy, which was a mandatory indication developed, or a BUN of 140 milligrams per deciliter. So about 278 patients were enrolled. And unlike the previous trials, the primary outcome was not mortality, but dialysis-free days. And what this arm showed that there was, or what this trial showed, is there was no difference in dialysis-free days, no difference in mechanical ventilation, no difference in hospital stay, no difference in dependence on renal replacement therapy. But when you did logistic and regression analysis controlling for confounders, there was an increased risk of death. So perhaps there is something about delaying it too long, which causes more harm. So again, these are the summaries of adding all the trials together. But what I want to mention to you, it's no different from the table I showed before, except that the AKK2 has been added, but there were some limitations to each of these studies and complications. Already talked about the limitations of the first trial, the Elaine trial. In the AKK trial, in the early arm, they saw more catheter-related bloodstream infections compared to the late arm. In the ideal ICU trial, it was actually stopped early due to futility, and then more hyperkalemia on the delayed arm. And the START AKI trial, the early arm had more dialysis dependency, as well as some other complications I will discuss. So what do we know about these trials? So 3 large randomized controlled trials demonstrate no benefit to earlier initiation based on an AKI staging of stage 2 or 3. In most trials, except for the Elaine trial, 30 to 40% of the standard arm never got renal replacement therapy, either because they died or they recovered kidney function. We always talk about maybe starting earlier is beneficial from a volume standpoint, but there was a limited accounting for fluid balance in these trials. The only trial that accounted for fluid balancing was the START AKI trial, the one with over 3,000 patients that was done internationally. And in the early arm, the median volume overload from initiation to ICU was about 2.7 liters, while in the late arm it was about 5.9 liters, but it didn't pan out to be anything significant. So volume status is not one of the reasons here. Maybe there's a possible benefit for earlier renal replacement therapy in surgical patients, but again, I pointed out some of the limitations of that study. We did learn that earlier renal replacement therapy may be associated with some adverse risks or adverse outcomes, which I already talked about. Besides the increased infections, increased dialysis dependency in that huge START trial of over 3,000 patients, there was also higher rates of hypophosphatemia and higher rates of hypotension seen in that early arm. Finally, we learned that very delayed renal replacement therapy may be associated with worse outcomes. So that's one way of looking at timing. Are there other ways we can look at earlier initiation versus the indications we usually think about? Well, another study done in Thailand used the concept of the furosemide stress test to stratify patients to an early or to conventional indications. And so these, again, this was a pilot study, so it's not powered to show mortality as an outcome. And I'm hoping that we see more from the center of a bigger study. But these were, again, critically ill patients with a diagnosis of acute kidney injury who essentially were given furosemide at 1 milligram per kilogram if they were furosemide naive, or 1.5 milligrams per kilogram if they basically had exposure to furosemide within the previous 7 days. And what was considered to be furosemide responsive is if they had a urine output greater than 200 cc's in 2 hours. That is how the furosemide stress test was done. What they did do is take those patients who did not respond and then randomize them to starting right then and there, or waiting to those complications that we know about, or those real acute indications. So it's interesting, the furosemide stress test does have good discriminating power, because if you can see here, those who fail the test in other words, less than 200 cc's in 2 hours, that essentially 87%, it was a very small study, required dialysis. Those who passed, in other words, that a urine output greater than 200 cc's in 2 hours, only 6% needed renal replacement therapy. Now, since it's not powered for outcome, there was no mortality benefit in this particular trial, but I'd like to see more of these results. So if you look at all the randomized trials done, whether you use staging of AKI or urine output, again, there seems to be no benefit to earlier, okay? But I wanna argue with you. How many of you in practice today use a staging of AKI to basically decide when to initiate renal replacement therapy? Okay, how many of you use a furosemide stress test? Okay, so these are the challenges we have as nephrologists. Some of you raised your hand. Essentially, we have to get our crystal ball out and predict what pathway these patients are going to take, what trajectory they're going to take. Some are going to get worse. Some, the creatinine may start plateauing or kidney function looking like it's recovered, and some may recover. And this is the prediction we have to do. And I would argue with you, as I'm sure all of you practice, there's so much more factors we consider. I rarely look at a creatinine as an indication to start renal replacement therapy. We think about this trajectory again. You know, what's the severity? We follow trends. I always tell my fellows, trends are your friends. I'm going to wear a t-shirt that says that next time. And so, you know, we follow these trajectories. We follow the trajectory of urine output. It's important to come back and relook what happens throughout the day and follow these patients closely. We look at the complications of uremia, the electrolyte derangements that are occurring. We even think about what's the likelihood the inciting event that causing the AKI is going to recover. What other organs are affected? Do we have heart congestion? Do we have liver congestion? Where's my liver? And do we have other things like that? What is the degree of fluid overload? Do they have pre-existing comorbidities? Are they already chronic kidney disease stage 4? And again, the trajectory is very important. And then of course, there's some real potential risks that we already talked about that we have to weigh this again. You know, sometimes if they have such a severe coagulopathy, and I think it's a risky procedure, I will do what I say is drag my feet and wait till there may be a more acute indication because I'm worried about the risk to the patient. And there's other factors that are realistic, essentially availability of machines. Do you have dialysis staff after hours? What about weekends? What about Friday? What about during COVID when we had no machines? So there's so many other things we think about that these trials cannot basically capture. So I think what I like is thinking about it, and this is where medicine is moving towards anyway, and I think this is very important in critical care setting, is that we need to look at the patient as an individualized approach. So I like this concept that was developed by a research group years ago, Acute group, and it's basically how I try to look at these patients in the ICU, is understanding that the kidneys have a limited capacity. And the degree and impact of fluid and metabolic derangements may vary between patients. And so there's basically this harm versus benefit curve depending on initiation. And early renal replacement therapy for one patient may be too late for a different patient. For example, we've all seen patients on ECMO who may have mild renal dysfunction. Creatinines may be not that elevated if you follow creatinine, no indications by acute indication by those electrolyte abnormalities, but because of volume issues and because of their lung, et cetera, we may need to start earlier than conventional indications. So you have to think about this early for one, maybe too late for a different patient. So I like this demand versus capacity concept. So you should consider acute renal replacement therapy. Specifically, these are for critically ill patients when the metabolic and fluid demands exceed what the kidney in that current condition capacity is. So now it's not based on a renal function or an AKI stage. It's really based on the ability of the kidney to meet demands. So what are these factors affecting the metabolic and fluid demands? We know about these. I've already mentioned these. The degree of fluid overload, solute load, their acute severity of illness, how many pressors they're on, what does their x-ray looks like, what are their other conditions? We take this to account on a daily basis. It's just hard to quantify. So I think we still have a lot of evidence gaps in initiation of renal replacement therapy, because although these trials were helpful, I don't think they've helped me much in terms of how I look at patients in the ICU. So besides the furosemide stress test, which I do use and it does help me, I don't look at staging. So let me ask you this. How many of you, based on these current trials, has changed your practice? I can't see a single hand that's elevated. So that tells you that. So luckily, there are further studies coming out. We've now realized what these trials have taught us, which we probably already knew, is that serum creatinine and urine output-based definitions may not be the best way of determining need for renal replacement therapy. And these future studies need to be done in whom benefits and not when in general initiation is more appropriate, the particular person. So I know several groups, including colleagues in my institution, are working on AI with clinical prediction by machine learning. I know that there are groups using predictive enrichment with specific AKI subphenotypes, since AKI is such a heterogeneous population, you want to find that group that will benefit by therapy. I know that in addition to the furosemide stress test that you all also use, or many of you use, the addition of biomarkers determine persistent severe AKI. There's more data coming out on that, and I think that's going to be very important. And also there are studies coming out with this kidney demand capacity mismatch. So Ravi made it in San Diego, and I was involved in this on this team. We basically took data from 4 different centers of over 100,000 patients to try to determine this demand versus capacity mismatch ratio to determine the appropriate indication or probability of needing dialysis. And so we looked at over 100,000, like I said, patients retrospectively in different databases in 4 different centers, 2 international. And then we validated this in over 80,000 patients in the Mayo Clinic database prospectively. And the area under the curve for our prediction, or his prediction, since he led this method, was 0.9. So there will be a paper coming out. And what this does, this demand versus capacity mismatch, is a ratio, and it's dynamic. It looks at the dynamic changes per day up to 96 hours prior to initiation, or prior to, when you think about initiation, and gives you a probability risk of needing dialysis based on the daily assessment. We still need more studies, but this is a first start. And I'm really excited about this, and hopefully I'll present that at some other time. So let's go on. So I talked to you about the issues and how to think about timing and where we are now. Always comes up, what's the best renal replacement therapy modality? And these are all the different modalities we have available in critically ill patients. So let's talk about what the data shows currently. So again, just a reminder, continuous renal replacement therapy is the slowest modality. It runs 24 hours a day. We're all familiar with intermittent hemodialysis, which is typically 3 to 5 hours a day and is a faster therapy with faster blood flows and faster dialysate rates. And then we have PIRT, prolonged intermittent renal replacement therapy, which is a hybrid, formerly or also known as SLED. And I think, how many of you here use CRT in your ICUs? So most of you, how many use predominantly SLED or PIRT? Okay, how many of you use both? Yeah, same here, we use both. So those are just a reminder of the differences in therapy. And again, if we go back to KDIGO, what do they say? Use them as complementary therapies, okay? Which means the data probably isn't that great, but they do say that in patients with acute brain injury who are at risk of increased intracranial pressure, probably CRT is better. And they do mention in that document that hemodynamically ill or unstable patients may benefit. So what's the data for that? So before I talk specifically about CRT, these are the meta-analysis of studies comparing intermittent hemodialysis to CRT based on older studies in the early 2000s. And this is one looking at mortality in the hospital, and again, no difference. If you look at mortality comparing PIRT to CRT, not surprisingly, as I mentioned, no difference. What about renal recovery? By these older studies, Guess what? You can repeat after me. No difference, okay? But if you look at these studies, there's a lot of limitations. They're very small. They're very heterogeneous. They use so much inconsistent dialysis operating characteristics, especially with CRT, because this is before we knew about dose and some of the things we know now. In addition to that, they were not adequately powered, as I mentioned. There were basically a lot of problems with the way the studies were done. There was a lot of crossover. So if patients were randomized to CRT and they could not get CRT run because it clotted all the time, guess what they did? Change them to intermittent hemodialysis. If you had patients on intermittent hemodialysis became hemodynamically unstable, they were crossed over to CRT. And in some studies, when patients were really hemodynamically unstable, those patients were excluded because the primary ICUs and clinicians did not feel comfortable in having the patients in their studies. So I don't think there's going to be any more studies looking at one modality versus another. But there are some benefits of CRT that I can point out. One is volume control. There are studies to support superiority of CRT when it comes to volume. The left slide here, or the left graph here, is a small randomized trial done in Cleveland Clinic years ago, looking at 3 days of fluid accumulation or removal, I should say, in patients treated with CRT, slow 24-hour therapy, versus intermittent hemodialysis. And what this study showed is that there was a statistically significant ability to keep the patient fluid negative with CRT compared to intermittent hemodialysis. And the reason for this, why fluid could not be removed with intermittent hemodialysis, is because the blood pressure went down and vasopressor support went up. On the right side of the slide is an observational study from 5 major institutions in the United States, the Picard group, who collected data prospectively, and they looked at patients specifically who needed renal replacement therapy at AKI in the ICU. And what they showed is that in the patients received intermittent hemodialysis, as indicated by the red dots, those patients accumulated fluid over the course of the days, while the CRT patients were able to have fluid removed. And what do we know about fluid accumulation in the ICU based on observational data? It's bad, exactly. So there's some data to support CRT. There are data to support CRT in the management of intracranial pressure. This was a study done a long time ago in patients with cirrhosis who had intracranial monitoring done by Davenport. And what he showed is when patients were put on intermittent hemodialysis, their intracranial pressure shot up. And I've seen that in the old days too, before we had CRT. And then when they put them on CRT, specifically CVVH in this particular study, the intracranial pressures did not budge. And the reason for that was secondary related to the drops in osmolality or the serum osmolality. Now, does that mean CRT is perfect and will not cause elevated intracranial pressure? No. There's case reports that CRT does that. So you still have to be very mindful with your CRT prescription in patients at high risk. So now, talking about some of the benefits of CRT, it always comes up, and this came up yesterday, today. Is there a benefit to convection versus diffusion when you use CRT modalities? Okay, how many of you think there's a benefit? That was a leading question, wasn't it? That's not fair. So just remember, convection is a process where basically you have a hydrostatic pressure placed across the membrane and plasma water is dragged or pulled through at such a high rate that you remove not only small molecules, but middle molecular weight molecules. And basically the rate limiting step of what can be removed is the size of the molecule. So does anyone know what the size of a CRT membrane is, the pore size? Average. Okay, I can teach something new. I tell my fellows this all the time, and I ask them the same question 1 month later, and I get the same response. So it's about 30,000 Daltons. The size of albumin in perspective is 55,000. So basically with convective therapy, you can remove small molecules, but also these larger molecules. We'll see if that's really important. While as we know, diffusion is concentration gradient based. It's based on Brownian motion. and it's really good for small molecules. So diffusive clearance is good for anything that's the size of about 500, 1,000 Daltons, which happen to be all our electrolytes, sputin, creatinine, while convective clearance potentially can remove molecules the size of the pore of the CRT membrane. Now, why is this important? What would be the benefit of removing these middle molecular weight molecules? Try saying that really fast. Why do you think there is some debate and controversy about wanting to use convective therapy? Anyone? So the thought process is many of these middle molecular weight molecules are the cytokines, right? And some studies have shown that cytokines can be removed, but they have not changed outcomes because either the generation rate or we're removing other things too. Also, just because the pore size is 30,000 Daltons, that doesn't mean you can remove molecules such large size. Because what studies have shown is protein layer and convective therapy occurs pretty fast. So the pores get obscured. And so essentially, really what you can remove is everything less than maybe 15,000 Daltons. So these are your CRT modalities, just as a reminder. Scuff is just a way to remove fluid, but the other modalities either use convection, diffusion, or a combination of both to remove solutes. So let me ask you, in this audience, who uses CBVH? Okay. Who uses CBVHD? Who uses CBVHDF? Yeah, so majority here uses CBVHDF, but again, I see a lot of diversity in this audience. So then, what do you want to use? Why do you choose one of those modalities that you talked about? Some of you who do CBVH, why do you choose it? Good response. Machine limitations. Okay, there's some things up here that help you with that. You got it. What about those who use CBVHDF? Okay, that will go on. This is why we talk about this. Yes? Okay, good. Good. So yes, I'm a big believer in standardization. We have 42 machines, and basically, if I didn't standardize this, I would never sleep. So what modality really depends on, what you already said, depends on the capability of your CRT device. So what I tell everybody is know your device well and what the limitations are. It's so important. And then the other part, which I've already alluded to, depends on whether you believe in convective versus diffusive therapy. So these are all the different CRT machines. And what I mean by know your device is certain devices may only be able to do CBVH or CBVHD. Certain devices can do all modalities, but may require some technical aspects. For instance, one of the common devices used requires a post-filter replacement fluid for a deaeration chamber. So the technical aspects of your machine sometimes dictate what therapy you can provide. But if you look at, again, and I've already kind of told you this or given the answer, are convective therapies better than diffusive therapies? Well, if you look at studies, but they're very old and they're very poor, basically they of course, everything in critical care when it comes to renal placement therapy. This was a meta-analysis that's really old now, comparing hemofiltration to hemodialysis for AKI. There were 19 randomized controlled trials, 16 used CRT. And what do you see? Any difference? No, not in mortality, as this is showing. What the study did show, though, is the studies were very heterogeneous. And in the convective therapies, there was more middle molecular weight solute clearance, but there was also more clotting because of this protein layer that was developing on the surface of the membranes. So where are we with renal replacement therapy? I would say use what works. I don't think there's going to be studies comparing one to the other again. It's just use your clinical sense. CRT, yes, it is preferred in cardiovascular instability, patients with cardiogenic shock, septic shock, patients who need volume control. It's much easier at our institution, at least, to do CRT daily and remove volume. Sometimes intermittent hemodialysis is difficult to do more than 3 times a week based on our resources. And for patients who are at risk of cerebral edema, I would definitely use it because I have seen bad complications with intermittent hemodialysis and used in those patients. And there may be some indications where a faster therapy is better. For severe hyperkalemia, I would not use CRT even if they're unstable. Some drug poisonings, or most drug poisonings, I would not use CRT. I will use intermittent hemodialysis, and if they're unstable, then transition them to CRT. And of course, if you can't get the CRT work because of coagulation issues. I think what we have to think of now, again, with this precision medicine concept, is we have a spectrum we can use, and you optimize the therapy based on your clinical condition of your patient, which is not static in the ICU, it's dynamic. Use what therapy makes sense at the time, unless we have better data supporting one or the other. Now, that being said, there are some studies that have come out more recently, observational, that suggest, looking at these huge randomized trials, that patients treated with CRT may have earlier renal recovery, which may be important, but yet to be determined. So when you look at the ATN and renal trials, which we will discuss briefly soon, these are the dose-related studies. They basically did an analysis of those patients with CRT versus intermittent hemodialysis and looked at 28-day renal recovery outcomes. So there was a total of 2,500 plus patients analyzed. And you can see a majority of them, as indicated here, received CRT. And what they discovered is that overall, there's no difference in renal replacement therapy dependence upon those two groups. But if they look specifically at survivors only, CRT was associated with a significant decrease in the 28-day renal replacement therapy dependence, okay, compared to intermittent hemodialysis. Then maybe it does make sense. CRT causes less hypotension. We know that intermittent hemodialysis could cause hypotension. If you look at the START AKI trial, the trial that looked at initiation, the largest trial, over 3,000 patients, they also did a secondary analysis looking at modality in terms of renal recovery. And what they showed by using propensity score and all these statistical analyses was that CRT was associated with significantly lower risk of death or renal replacement therapy dependence, but this was primarily driven by the dependent or the use of CRT, by the way, not death. Okay, but basically, again, there may be a signal that CRT may lead to earlier renal recovery, which we know is important. So wait to be seen. Finally, this was just published this year, looking again at the same concept or the same idea. This is basically what they did is they took a retrospective analysis, this group of US hospital discharge data linked to claims. It's again observational. They looked at 34,000 patients, and they looked at renal replacement therapy dependence at 90 days post-discharge, and that signal seems to apply to this study too. And these are more recent data as compared to the meta-analyses that I showed you before, but again, observational. So where are the evidence gaps in terms of modality? Well, again, we really don't know the best renal replacement therapy modality to promote renal recovery, but there's some suggestion in observational studies more recently that may be CRT. We need more studies. And what about the effects of modality and solute clearance? Yes, trials have not shown convection is better than diffusion, but those were old studies. The newer membranes used with CRT actually provide enough back filtration that they have great convection abilities, even in a diffusive modality. So may not be that important, and that has not been looked at since a long time ago. So we need to look at it again. Another area that we don't know is how to appropriately transition between modalities. Do we need to de-escalate? Do we need to just stop? What is best for the patient? Okay. So, and I know there are future studies again, because I've been involved in some of them that will hopefully help us with that data. So now what about optimal dose of CRT, or excuse me, renal replacement therapy? So just before we talk about dose, all of you know how dose is measured with intermittent hemodialysis. We look at a KT over V. In CRT, I like CRT because the math is so much simpler. So we always think about dose as nephrologists, clearance of small molecules such as urea. So in CRT, whether you use convective or diffusive therapy, for most small molecules, anything less than 500 Daltons, The concentration of the ultrafiltrate or the effluent approximates that of plasma water. And so since, unlike intermittent hemodialysis, the effluent flow is much lower than the blood flow, you can get equilibration between the plasma and what comes out in the effluent. And so dose for CRT for urea clearance is strictly proportional to the effluent rate. The higher the effluent rate, the higher the dose and clearance of toxins. So if you look at the dose of CRT, what do I mean by effluent rate or effluent? What is the effluent? It depends on the modality. For CVVH, the total ultrafiltration, which means your replacement fluid, the rate that the replacement fluid's running, because that same amount is pulled through the filter as plasma water plus your fluid removal. For CVVHD, which is diffusion based, it's a spent dialysate plus ultrafiltration or fluid removal, and for CVVHDF is a combination. So essentially it's everything that comes out in that effluent bag you see on the machine. That is equivalent to urea or creatinine clearance. And how we express dose for CRT is in milliliters per kilogram per hour. So just again, to highlight the difference between convection and diffusion, it doesn't matter which modality you use. Whether you use convective or diffusive clearance for the same effluent rate as demonstrated by these graphs, your solute removal for small molecules is linearly proportional to dose. The only difference occurs, as you can see by the graph on the left side, is if you believe in middle molecular weight molecules being removed like beta microglobulin or cytokines. You can see in the convective therapy by older studies with older membranes that middle molecule clearance was greater. So from my perspective, I don't see any difference between the two. So when you look at dose, these were the guidelines that KDIGO, again, published over 10 years ago. Where do these guidelines come from? At least a K2RV guideline and the effluent rate for dialysis or renal, for CRT. So there are two major studies that I'm sure you're all aware of. One was the ATN study done in the United States, looking at timing of dose, or optimal dose, I should say, not timing. And one in New Zealand and Australia, looking at the same thing. Both are multi-center studies. The ATN trial looked at all modalities of dialysis, and basically there was an intensive management strategy versus a less intensive management strategy. So those patients were hemodynamically stable, determined by a SOFA score. They were randomized to receiving dialysis 3 times a week versus 6 times a week for achieving a K2RV of at least 1.2. For those who were hemodynamically unstable, the primary investigator at the sites had an option to either use CRT at a dose of 20 would be the minimal dose versus 35, or SLED or PERT. Again, 3 times a week versus the intensive strategy 6 times a week with the K2RV that was measured. The renal trial, on the other hand, specifically just looked at CRT. A dose of 40 milliliters per kilogram per hour versus 25. And all of you know, what do these studies show? No difference in terms of outcomes, i.e., is more better? No. Surprise, we learned that even in the chronic intermittent hemodialysis therapy, more is not always better. But it did establish the standards for today. So for CRT, what's recommended is a fluent rate of at least 20 to 25 liters per kilogram per hour. Now keep in mind, in both these studies, dose with CRT is not just the volume of effluent, it's also a component of time on CRT. So in both of these studies, patients were on CRT more than 20 hours a day. In your patients that you look at, what is the average time patients stay on CRT? So historical data has shown about 16 hours due to time off from clotting versus procedures, et cetera. So keep that in mind. So basically that's what's recommended as long as there's careful attention to ensuring that the target dose of therapy is actually delivered. How many of you measure what you deliver? How many of you measure anything? Hey, look, I'm here talking about this and even my institution doesn't do it. So yes, we could be better. We need to be better. For intermittent hemodialysis, the study showed, if you're going to use that, there is no need to provide treatments more than 3 times a week as long as you achieve that target K2RV. But many times extra hemodialysis sessions were needed for fluid removal. How many of you measure K2V in your ICUs or on your patients in intermittent hemodialysis with acute kidney injury? How many measure urea reduction ratios? Who are the fellows in the audience? Okay, so fellows, when you prescribe intermittent hemodialysis to your AKI patients at critical in the ICUs, how many hours do you prescribe? Okay, let's in general. Okay, you're doing a lot better than us in other places, because most of the times, most places, if you look at it, prescribe about 3 hours, okay, which is even less than what we get in an outpatient setting. Why is that? Because if you have a lot of mobiles, meaning that a dialysis nurse has to go to the ICU to deliver therapy, it's resource dependent. So how many of you fellows sometimes get a call from your dialysis nurse saying, can we decrease the time by 15 minutes? Oh, I'm seeing that happens here too. And what do you guys do? Yes. What are you going to do? You're going to argue with the dialysis nurse? I don't argue with my dialysis nurse. So that happens. So if you look, we did a quality improvement project, and we couldn't measure K2Vs. It's very hard in the inpatient setting, but we measured urea reduction ratios. Okay. And it correlated, basically urea direct injection ratio of 65% correlates with a K2V about 1.2. We were actually getting a K2V of about 1. So we could be better. And these were patients actually even in our inpatient dialysis unit, not even the ICU. So I think the problem is yes, we have these guidelines, but we're still not following them because we're not measuring them. And I can assure you, I need to do a better job. So I need to be a better role model. Okay, let's specifically look at high volume hemofiltration, because everybody wants to believe that convective therapy is better. It really mimics what the kidneys do. These were studies looking specifically at real high hemofiltration, just convective clearance, at doses of 85 milliliters per kilogram per hour. These were all randomized trials, all small centers. And what did they show? No difference in mortality, no difference in renal recovery. Some showed yes, there was an earlier decrease in pressure requirements, but when it came to these other outcomes, there was no difference. Why do you think we've not shown any difference? Because it seems to make sense. Some studies have shown cytokines can be removed. What are the problems with these studies, you think? So if you look at these studies, is the pore size of a CRT membrane selective? No, so what else are you removing? We have a lot of data now that minerals can be removed, vitamins can be removed, good things can be removed, antibiotic dosing is difficult. So some of the argument I can give you is perhaps we're removing some of these good things too that we're not recognizing because we didn't measure them. And the other argument is look at the size of these studies. They're very small and they can be underpowered. A lot of these patients develop severe hypophosphatemia. And we now know by observational studies that hypophosphatemia is associated with delayed ability to get off the ventilator. So you see, there's a lot of things to consider, so we just don't know yet, but I can't advocate convection at this time based on the evidence for those reasons. So this is where we stand today. That there is a dose that's considered to be safe. We don't know what the lower level of that dose is, considering it's, by the studies shown anywhere from 20 to 40 milliliters per kilogram per hour. Some studies from Japan have come out and said you can actually even go to maybe 15, and lower than 15, they may have some adverse outcomes. We still need to know. What else is problematic with these dose studies? Before I go on. What did we look at the molecule or marker? Urea. There's so much else that we look at for dosing. Acid-base status, hyperkalemia. We may use a higher dose for various reasons, ammonia clearance. So I think we need better studies to actually measure what's removed to really be able to target a dose. And again, I think it's going to be individualized. How many of you prescribe a static dose to your patients during therapy? In other words, you achieve that 25 or 30 milliliters per kilogram per hour, and that's the same dose you use throughout your CRT. Most of us do. That wasn't a trick question. But the patient's clinical condition changes. And so I think we need to think more of dynamic dosing in the future. How many of you had a patient on maybe 25 milliliters per kilogram per hour and your BUN is less than 6 and their creatinine is like 0.04? Do you still use that dose? No, I use a lower dose because I think that's right. I mean, the kidneys need to have some solute clearance to work. There was a patient in our ICU that had normal kidney function, was not on CRT that long, had no reason for her kidneys not recovering, and her BUN was less than 4 and creatinine 0.3. And I said, the kidneys have no reason to respond. Urine output's depending on solute load. They all laughed at me. I said, just stop it and give her time. And she'd been on for 2 months. Okay, so it was that long. She recovered kidney function. So I do believe that's an anecdotal book. And I looked like a hero that day. The one time in the surgical unit that I look smart. Okay, so what about volume removal? There's more data now coming out that potentially, just like with hemodialysis, that excessive ultrafiltration may be bad. There may be an ultrafiltration rate that may be best for improving outcomes or volume removal. This is very preliminary data. It's observational. And this is a post hoc analysis of greater than 1,400 patients from the Renal trial, which looked at dose. And there seemed to be a zone of safe ultrafiltration net of between 1.0 to 1.75 milliliters per kilogram per hour. So there's more studies now looking at, is there a fluid removal rate that's associated with better outcomes? Now, again, take this with a grain of salt. This is observational. But as with intermittent hemodialysis, there are now reports coming out with CRT that there's cardiac stunning too, although the mechanism is not currently understood. The investigators who reported this study are actually doing a feasibility trial right now. It's Mayo Clinic in Pittsburgh, looking at the feasibility of giving a higher ultrafiltration rate versus a lower ultrafiltration rate, meaning fluid removal, I should specify, and set up for a bigger, huge randomized trial. So stay tuned. These results will hopefully be out in the next 1 or 2 years. So we still have a lot of evidence gaps in dosing, like I mentioned. We need to look at other electrolytes, acid base, and other solutes, and think of a dynamic approach rather than a static approach. We really have limited data on appropriate dosing of antibiotics, but I would argue it's even more limited in PERT patients. I have no idea what to do when I have a patient on PERT. We have limited data of the assessment of nutritional losses. We are now recognizing that there's significant nutritional losses, but the jury is still out on whether replacement of these losses leads to improved outcomes. This is a great area of research. And again, as I mentioned, there's no data on dynamic CRT dosing, but there are more data coming out. And I think with machine learning, artificial intelligence, maybe we'll have better data if the quality of data going into these models is good. Last 2 minutes, what is the optimal anticoagulant? I just want to say by KDICO recommendations, all this slide says is what is better? Citrate. If you're going to look at me, you're going to know I'm going to say citrate. But this is based on good studies. This is a meta-analysis of 13 randomized controlled trials comparing heparin to citrate in 1,600 patients. And the signal is there. There's greater patency of the circuits and decreased blood requirements or transfusion requirements in those patients on heparin. The largest study was done a couple of years ago with 600 patients done in Germany, the same investigators who did the Elaine trial, and they showed that, again, just what I said. One thing to be aware of, though, is the study did show, for whatever reason, at a post hoc analysis, that those patients on citrate had increased risk of infections. When they went back and looked at their data, it had nothing to do with the anticoagulant. It actually was the actual circuit life. The longer your circuits lasted, the more risk of infection. But please, again, post-hoc observational data, very small studies. It's provocative. I know this group is looking at this more intensely. Just keep that in mind. All right, finally, where do we end? Yes, we still have a long way to go, but I do think we've made progress. I can tell you, because of improved care, whether it's the ICU or whether the way we look at dialysis in the ICU, our mortality has gone down. When we first looked at this, when I finished my fellowship, from 80% to now our mortality is more like 40 to 50%, which corresponds with the literature. There's no overall benefit to CRT compared to intermittent hemodialysis. Again, the studies are controversial, but I would argue, yes, if there's a patient who has risk of increased intracranial pressure, I will use CRT or hemodynamic instability, and it was my family. There's no benefit at this time for a particular CRT modality. You all use different modalities. Whatever modality you use, my advice is to stick to one modality and use it to the best, where it actually runs and is continuous and you achieve your goals of CRT, fluid removal, solute control, metabolic control. There's no benefit to intensive therapy at this time. There are guidelines of what we should be prescribing, but that doesn't apply to patients who have other knee reasons to have a higher or lower dose. For those patients at higher intracranial pressure, I will use a lower dose initially, so I don't cause the osmotic shifts, since there are reports of increased intracranial pressure with CRT. And yes, with anticoagulation, there are enough studies to propose or show that citrate is better. There's no other options right now, but I think we need better ability to deliver citrate safely in the United States. So thank you very much for your time, and I hope you learned something today, or maybe I'll have to come back, but we have more evidence of these things. I think what's going to be important too is having some sort of quality assurance program too, looking to achieve, if you're achieving at least these minimal goals. How many of you right now, I'm going to ask the question, how many of you right now have quality improvement or assurance programs in your acute dialysis and ICU to look at things like this? Yeah, so you should do this to know your filter life. Are you adequately achieving your goals? I mean, we do have quarterly meetings to discuss this, but it's something you need to be considering, because I think we're going to be held to a benchmark soon. There's benchmarking coming out of what you should achieve in terms of acute renal replacement therapy in the hospital now. So we're going to be accountable at some point. Other questions? Yes. 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 Vitamin C is really easily removed, correct? So Marlies Osterman and others have good studies about what has been removed. If you email me, I will send you those studies. Those are in the adult populations. I'm not aware of children's. So my email is very easy, Ashita Tolwani, TOLWANI at uab.edu. But please do, and I can send you all the nutritional studies. Yes, there is some information about TPN2 in those. Yes. So, all these patients are presumed etiology based on examination of urine and clinical course has been ATN. But you're right, these are heterogeneous populations, and that's where we have to do subtyping of phenotypes. And with some of the work that we've done with this demand versus capacity ratio, we have identified 4 different subtypes based on not so much the etiology, but AKI in consideration with other comorbidities that may show a difference in how they respond to renal replacement therapy. But yeah, we need to populate our groups with much more homogeneous population of those who would benefit. I don't know if that answered your question, but that's all we can do at this point. And I think biomarkers, would be very helpful with that too. And incorporating those biomarkers will help with that aspect. Yes.
How we, as nephrologists, make changes in CRT dose without thinking what it does to, without it does to antibiotics. I just wonder how much of the high mortality or progress is do with people getting the antibiotics they need. How do you think about it?
I do, and that's difficult. I think we need better assays to actually measure. Most people will say that unless you have a toxic antibiotic, most of those levels can be measured, like vancomycin or aminoglycosides, to err on the sides of giving a higher dose. So you can go to any patient on CRT and estimate the GFR from the machine. You can take the effluent dose and milliliters per kilogram per hour, divide by 60 minutes to put in milliliters per minute, and combine it, if you're using pre-dilutional fluid, by the dilutional factor. So if you do that for our dilutional factor, how much we're diluting our blood by is about 0.8. That gives you a sense of a reliable, not reliable, but more reliable than other measures. And this is what we do on a daily basis. My fellows look at is the estimated GFR delivered by that machine. And so, if patients are on medications that are cleared renally, that you can predict or estimate doses. Another concept that's come in play in the literature is looking at this e-kinetic equation every day and trying to incorporate with these CRT modalities where they can predict dosing of antibiotics. But yes, we have a long way to go. And the short answer is we need to measure it. The long answer, or even short answer, is err on the sides of giving a higher dose or normal doses. Yeah, so nafamostat is a proteaserase inhibitor, I believe. It's used often in Japan. It's also used in South Korea. I just learned that recently. It has less side effects and less monitoring needed than some of these others. But in preliminary studies comparing nafamostat to heparin, it was showed to be inferior, but much better than no anticoagulation. It's not available in the United States, so I think it is an option, but nothing's been compared between citrate. But we already know citrate's better than heparin, and heparin's better than nafamostat. I'm not sure it's going to be the end all for everybody. Maybe in certain populations better than nothing. Great question. There is a trial, if I'm not mistaken, that they're trying to do in the United States looking at nafamostat. I just don't know if it's been started or where it is, but I know that they've approached us to look at that too. Have you had experience with it? And what did you think? No, but that's good. You know more than I. You had experience with it. So what did you think of it? Okay. Nothing. Yeah. 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 I mean, it's still better than nothing, maybe beneficial. I think there's more studies that need to be done. So thank you for your experience. Yeah, I can't think of any way which CRT works that would be true. And I've not seen a difference. I've actually used both convective and diffusive for various studies and have not seen a difference. What comes up with that is there's some clearance of vasopressors. Yes, for both there are, but what are you going to do? Just increase your doses. It's very minimal. Yes, again. No. Well, not in pressure requirements, but more intensive therapy in most of those studies were associated with delayed renal recovery. Okay, so whether that's, wasn't identified as there were some hemodynamic shifts that weren't noted, but that's a good point. That is a possibility with the more intense arms or clearance, but it's not been elucidated. Great question. Yeah, more intensive is not better. Yes. Nobody. It depends on who you ask. CV surgery says they're in charge and everybody's like, on 400 cc's an hour until I come in. No, but your question is well framed. I think, Volume status is very, very difficult to tell in ICU patients, but we do have tools that we should be using. POCUS, I'm a strong believer of POCUS in certain situations. Using other techniques like pulse pressure variation, the cheetah, using all those techniques you have, echocardiogram is needed. And looking also at trends. I really believe in trends, seeing the effect on blood pressures, et cetera. The problem is even though we have all those tools, they're not routinely used because I think they increase the workload. But if I were the person who's a primary in the ICU, I'd be using all those tools to give me a better idea of what I'm doing. So I don't have a good answer for you, but that's all I have. But I would tell you, put 5 people on one patient, all will have a different answer of how much fluid needs to be removed. Yes. I'm not aware of any data supporting that. So I'd have to have more information on why that person thinks so. To be honest. Thank you.